special tests that we'll go into detail and stuff. So I'll go ahead and start with the examination. I'm going to wash my hands and introduce myself. Hi, my name is Christina. I'm the PA student. I'll be the one doing your musculoskeletal examination today. First, I'm assessing the TMJ. I'm inspecting. I'm looking for symmetry, any unusual masses. I'm palpating, feeling the bony landmarks just anterior to the tragus. I'm going to have the patient open and close their mouth. I'm feeling for any crepitus, pain, tenderness, any retraction and protrusion, forward and backwards of the lower jaw, please, and side-to-side movement. Again, feeling for crepitus or pain. I'm going to have the patient stand up and I'm examining their C-spine. I'm looking to make sure that it's midline. I'm palpating each spinous process. And then the muscles on the side of the neck and the trapezium. And then I'm inspecting the lumbar-thoracic. I'm looking at the side for any lordosis or kyphosis. Can you just lift up the back of your shirt, please? Yes, please. Just the back. I'm palpating each spinous process. First, I would inspect, looking for midline, checking the skin, looking for any rashes or lesions, then palpating the spinous process, and then the paravertebral muscles. I would also palpate the sacroiliac joint. On the neck, I would check for range of motion. Place your chin down to your chest, please. Flexion. Look up at the ceiling. Extension. Put your right ear to your right shoulder. Lateral bending to the right and to the left. And then rotate your chin to your shoulder on the right. Rotation. And same thing on the left. The hips, I'm going to stabilize. Ask the patient to please touch their toes. Flexion. And extension. I'm sorry, of the spine. Extension of the spine. Go ahead and lean back a little bit, please. Okay, and then lateral bending. Lean towards the right and the left side, right side. And then rotate your shoulders to the right and the left. Okay, then I would assess the shoulders. First, I'm inspecting. I'm looking for symmetry, any deviations or malformations. I'm palpating. I'm going to palpate the sternoclavicular joint, the clavicle, the acromioclavicular joint, the acromion, the AC joint, the coracoid process, the greater tubercle of the humerus. I'm going to bring the patient's hand back and feel the head of the biceps tendon, and then the biceps groove in the humerus. I would do this bilaterally. Then I'm checking the range of motion. I'm going to ask the patient to bring their arms up, flexion, extension, abduction, adduction, external rotation, and internal rotation. Then I would do a few of the special tests. I would do the empty can test, asking the patient to hold two cans, pretend like you're emptying them, and push up against my hands, checking the supraspinatus integrity of the muscle. Then I would have the patient bring their arms at the side 90 degrees and try to abduct the hands, push against my hands, checking the integrity of the infraspinatus muscle. Then I would have the patient bring their arm to the side and do the drop arm test, slowly lower it. It's a normal finding. If you're testing the rotator cuff, if there was a tear, then their arm would suddenly drop. I would also do the Apley's scratch test. I would ask the patient to place one hand behind their neck and the other from the bottom. Try to touch both fingertips. And the other side, checking for pain, tenderness, or limitation in motion, checking the rotator cuff again. Go ahead and sit down. Then I'm inspecting the elbows. I'm looking for any abnormalities, any inflammation. I'm palpating. I'm feeling the lateral epicondyle, the medial epicondyle, the olecranon. I would do this bilaterally. Then I'm checking range of motion, flexion, extension, arms at the sides, supination, palms up, pronation. And I would ask the patient to try to supinate their hands against resistance to test the strength. And I would also do the valgus and the varus stress test. Valgus, testing the medial collateral ligament. Varus, testing the lateral collateral ligament. I would then examine the hands, the wrists, and the fingers. I would palpate the radius, the ulna, the distal radial ulnar joint, the anatomical snuff box where the scaphoid is, the carpal bones, the metacarpals, the MCP, metacarpal phalangeal joints, and then the PIPs, the proximal interphalangeal, and the distal interphalangeal, the DIPs. I would do this on both hands. I would then have the patient grab their thumb and make a fist and ulnar deviate to check for decurvain tendinitis, which would be inflammation of the first dorsal compartment of the extensors to the hand. I would check for Tinel's and ask if it elicits numbness or tingling in the first 3 and part of the 4th fingers, checking for carpal tunnel. I could also do it at the elbow, checking for cubital tunnel. That's Tinel's test. And then I could also do Phalen's test, ask the patient to hold for 60 seconds and see if their hands fall asleep. If so, a positive Phalen's indicative for carpal tunnel. And then I would assess the hips. I would ask the patient to please lie back. First I'm inspecting, I'm looking for symmetry. I'm going to palpate. I'm feeling the iliac crest, the iliac tubercle, the anterior superior iliac spine, the greater trochanter of the femur, and then you can verbalize, you would palpate the pubic symphysis as well. Then I'm checking the range of motion. I would place my left hand underneath the back of the patient and ask the patient to lift up their leg and feel their back come against my hand. Flexion, and then extension of the hip. Come over to the side of the bed, please. And keep the leg as straight as possible and extend back as far as you can. Extension. Another way you can check is have them go on their stomach and lift their leg up behind. Either way is correct. Then I would check for abduction and adduction. I would support the opposite hip, or stabilize. Adduction and abduction of the right hip. And if it was done on the left side, I would use this hand to stabilize the opposite hip. Adduction and abduction. I would also do external rotation and internal rotation. This is in regards to what's going on with the acetabulum in the hip joint. Internal rotation and external rotation. Then I would inspect the knees. I'm looking for symmetry, any inflammation, any trauma, lesions, sores. I'm palpating the patella, the tibial tuberosity. I would ask the patient to bend their knees, the medial collateral ligament, and the lateral collateral ligament. I would do on both sides. Then I would ask the patient to please tighten their quads and look for the grind test, which is the rise of the patella. Quite tighten, good. Then I would check for range of motion, flexion, extension. Then I would check the valgus stress test by pushing on the lateral side, valgus stress of the knee, assessing the medial collateral ligament, and pushing on the opposite side, varus stress, assessing the lateral collateral ligament. I would do that on both sides. I would perform the anterior-posterior drawer test, placing both hands behind the knee, pulling forward, looking for a prominent endpoint, testing the ACL, the anterior cruciate ligament, for possible injury or tear if the knee was to slide forward, and pushing back in the same manner, testing the posterior cruciate ligament, the PCL. Then I would check for ballottement. I would place my hand above the patella and push up on the patella up towards the femur, and I'm testing for effusion. I'm looking for effusion to come across the top of the kneecap of the patella. The ballottement test. And then the bulge test, I would push from the lateral side, and I'm looking for effusion or a bulge sign on the inside of the knee. Mcmurray's test tests for municipal injury. I would have the knee bent, and I would rotate and extend at the same time. In this fashion, assessing for lateral municipal injury. And then if I internally rotate and straighten, for medial municipal injury. The Mcmurray test. Then I would have the patient sit up. I'm inspecting the lower legs and the feet. I'm looking for any corns, calluses, any abnormalities, flat feet. I'm palpating the tibia and the fibula, the medial and lateral malleoli, the Achilles tendon, the calcaneus, the tarsals, the metatarsals, the MTPs, metatarsal phalangeal joints, and the interphalangeal joints. I would ask the patient to lift their foot up towards the ceiling, which is dorsiflex, range of motion. Push down on the gas pedal.